myself, Dr. Yuvraj V. Panchal, working as a senior cardiac physiotherapist in UN Mehta Institute of Cardiology and Research Center since 10 years. In this continued physiotherapy education, today I present you decortication and its physiotherapy management. What are the key points of today's topic? Introduction of decortication. What are the indications for decortication? What are the contraindications for decortication? Aim of surgery, surgical procedure, physiotherapy management. First, pre-operative phase. Second, immediate post-operative phase, day 0 to 1. Third, early post-operative phase, day 2 to 5 day. Fourth, late post-operative phase after drain removal to discharge. Fifth, post-discharge rehabilitation. Definition of decortication. Decortication of the lung is surgical procedure that is done to remove fibrous tissue that envelops the lung, the chest wall and the diaphragm to enable to normal expansion and deflation of lung during respiration. The pleural can be affected by pathological condition resulting in the filling up of this space with filling or tissue leading to formation of pleural ring that prevents the normal inflation and deflation of the lung and leads to breathing difficulties. Now, indication for decortication. Fibrothorax, a condition where the pleura bracket lining of the lung becomes thin and scared, restricting lung movement. This can result from various causes including infection, trauma or inflammation. Malignant mesothelioma of the lung, a type of cancer that affects the pleura. Decortication may be part of a pleurectomy/decortication procedure to remove the tumor and affected pleura. Pleural empyema, a collection of pus in the pleural space. Decortication is often considered when empyema persistent despite antibiotic treatment or if it becomes chronic. Clearance of infection. Hemothorax, the presence of blood in the pleural space which can lead to similar restrictive changes in the pleura as empyema. While drain is often sufficient, decortication may be necessary if the blood clots and thins the pleura. Pleural thickening. Now, contraindication for decortication. Presence of pleural space infections, large airway narrowing, uncontrolled lung infections, coagulopathy, lung infection or disease of the other lung, several chest wall disease or infection. Aim of surgery. Restoration of lung expansion, removing source of infection and prevention of deformity due to fibrothorax. Now, surgical procedure. Mainly in surgical procedure using two different techniques. First, open thoracotomy and second is video assisted thoracoscopic surgery. First, I describe you open thoracotomy. Posterolateral thoracotomy is done. Enter into the thoracic cavity is established via 5th or 6th intercostal space. I show you in this image. Enter into thoracic cavity via 5th or 6th intercostal space. A rib resection might be required if there is excessive crowning of ribs. After the division of intercostal muscle, the extrapleural space is entered. In this figure, cut out the intercostal muscle and enter into the extrapleural space. The mediastinum is generally not involved in inflammatory processes. Therefore, care must be taken to avoid injury to mediastinal structure. The apex of the lung must be freed carefully because injury to subclavian vessel may occur during apical dissection and can cause hemorrhage. Care taken to avoid injury to esophagus or vena cava during medial dissection and diaphragm during inferior dissection. The pleura pill must be removed from the lung parenchyma including the fissures. After removal of thick pill, the lung is inflated to locate the air leaks. All the major air leaks must be closed with suture. The intercostal drain is inserted in the thoracic space, interspace. Some surgeons insert two drains, one in the base and one in the apex. Subsequently, chest wall closure is done. Now, second procedure is video assisted thoracoscopic surgery (VATS). VATS. In this procedure, thoracoscopic decortication, this method uses small incision and a thoracoscope (a camera with a light source) to guide the surgery. I show you in this figure, make a small hole and inserted a camera with light source. Surgical instruments are inserted through the other small incisions to remove the pill and clean the area. Make other small holes and inserted a surgical instrument to remove the pill and infection. VATS is considered minimal invasive and generally result in a shorter hospital stay and faster recovery compared to open thoraco. What are the complications after decortication? Hemorrhage, persistent air leak and bronchopleural fistula, persistent lung collapse, injury to vital structure, infection and sepsis, several post-operative pain, chest wall deformity and scoliosis. Now, what is the physiotherapy management after decortication? First, we start with the preoperative phase. Take a detailed assessment of patient, detail in history, presenting symptoms like dyspnea, cough, sputum, chest pain, functional limitation like reduced activity tolerance, fatigue, smoking history, comorbidity like COPD, cardiac disease and diabetes. Take a clinical examination of patient, inspection, chest wall movement, posture, accessory muscle use, pulsation, asymmetry, frematus, percussion and auscultation, dullness, reduce breath sound, SpO2 on Romer, pulmonary function test if available, check FEV1, FVC, EBG analysis, check patient pH, PO2, PCO2, HCO3 and electrolyte, exercise tolerance test, 6-minute walk test, optional. Physiotherapy goals: optimize pulmonary status, clear secretions, improve thoracic mobility, educate and train for post-operative recovery. Interventions: first, breathing exercise, diaphragmatic breathing, Diaphragmatic breathing is also known as belly breathing or deep breathing. How to perform diaphragmatic breathing? First, you lie down in relaxed position. Place your one hand on your chest and another on your abdomen. Take a deep and slowly breathe through your nose and focusing on your belly. Then exhale air through your mouth and relax. Segmental expansion on affected side. Segmental breathing. Type of segmental expansion. First, apical expansion. Second, posterior basal expansion. Third, lateral costal expansion. Fourth, right midlobe or lingular expansion. How to perform segmental breathing exercise? First, you identify the affected area. Give a proper position like lying on your back or sitting upright position or lie down on your side according to affected area. Place your hand on chest wall overlying the segment which you targeted. Take a deep and slowly breathe through your mouth and direct the air towards you, hand applying pressure. Now hold a breath for 2 to 3 seconds. Exhale air through your mouth and relax. Incentive spirometer. How to use an incentive spirometer? Sit upright in comfortable position. Exhale normally to empty your lung. Take a mouthpiece in your mouth and tightly close your lips. Take a slow and deep breath through your mouthpiece and trying to make a ball rise according to your targeted goal. Hold your breath for 2 to 3 seconds and or as long as possible. Exhale slowly and remove your mouthpiece. Airway clearance, active cycle of breathing technique, ACBT. Active cycle of breathing technique. Start with breath control. Do a 3 to 5 time deep breath. Breath control. Do a 2 to 3 times huff. Again breath control and do a cough. Huffing and splitting coughing. Mobility training. Mild aerobic activity like walking, shoulder mobility, gentle range of motion exercise, education, role of physiotherapy, demonstrate coughing, huffing and supported sitting. Post-op expectations, pain, chest drains, early mobilization, smoking cessation counseling if needed. Second, immediate post-operative phase, day 0 to 1. Assessment, vital signs, ABG, SpO2, drain tube and incision site, pain according to visual analog scale, sedation level, lung auscultation, cough, stretch and secretion characteristic. B. Goals: prevent pulmonary complication, atelectasis, pneumonia, promote lung expansion, initiate gentle mobilization. C. Interventions: positioning, head and elevation bracket 30 to 45 degree, frequent position changes every 2 hourly, operated side up if tolerated. Breathing exercise: diaphragmatic breathing, incentive spirometer every 1 to 2 hours, airway clearance, ACBT technique, huffing or supported coughing, splitting, chest physiotherapy, percussion and vibration if sputum retained, postural drainage if tolerated and indicated, mobilization, bedside sitting, dangling legs, standing with support, ambulation as per vitals. Third, early post-operative phase bracket day 2 to 5. Goals: improve lung volumes, restore mobility and endurance, prevent shoulder stiffness. B. Interventions: breathing and expansion, incentive spirometer every hourly, deep breathing with breath hold, airway clearance, ACBT with huffing, suctioning if ineffective cough, mobilization, progressive ambulation bracket distance increased daily, stair climbing if able, shoulder exercise, full passive and active range of motion, wall walking, pendulum exercise, posture training, avoid protective posture on operated side, thoracic mobility exercise, lateral trunk stretches, scapular mobilization. Fourth, late postoperative phase bracket after drain removal to discharge. Goals: maximize lung function, improve endurance, restore full mobility. Interventions: continue all previous breathing and airway clearance techniques. Aerobic trainings: walking 3 to 4 times in a day. Progress to 20 to 30 minutes in a day. Strengthening: gentle upper limb resistance exercise bracket post drain removal. Monitor: oxygen saturation with activity, cough effectiveness, signs of infection or infusion reaccumulation. Fifth, post-discharge rehabilitation. Home program, breathing exercise, diaphragmatic and incentive spirometer 3 to 4 times in a day, airway clearance, continue if productive cough. Walking program, increase gradually and aim for 30 minutes in a day. Shoulder and thoracic mobility, continue full range of motion and wall exercise. Posture correction, avoid slouching and guarded posture. Follow up physiotherapy if needed. Pulmonary rehabilitation program for high risk or deconditioned patients. Spirometer at 6 to 12 weeks if pulmonary reserve was poor. I heartily thankful to our director, Dr. Chirag Doshi sir, and HOD of Physiotherapy Department, Dr. Aisa ma'am. I also thankful to listener to give your valuable time. Thank you.